Ladies and gentlemen, thank you for giving me the opportunity to discuss this very interesting topic. So whenever we talk about non-alcoholic fatty liver disease, we have to look at it through the prism of the obesity epidemic, not just in the United States but worldwide. So this slide is of the longitudinal transition of obesity trends among U.S. adults from 1990 up till 2008. So it's a relatively old slide now. So it's 11 years old, but it just gives a great theme around how obesity trends have grown and how the obesity epidemic has taken off in this country. And there's a real significant increase. You can see that in 1990, there was there were some states that were in the blue that had that around that 10%. Some had 10 to 14% obesity trends. 99, those trends are starting to move to the right with increasing percentages. And then by 2008, and these trends are getting even worse into 2019, where there's more and more states that have large rates of obesity over 30%. And I think this slide depicts very, very importantly about how it's not just an epidemic of adults. It's an epidemic that's occurring across all lines in the pediatric population as well. And the reason this is important is because it's a pediatric disease, and obesity is a pediatric disease. All these young children who are obese now are going to hit adolescence and then hit young adulthood and become adult obese patients and start getting the morbidity and mortality seen with the metabolic syndrome at a much younger age. So we're going to be hit by an epidemic of metabolic syndrome and its associated diseases in a much younger population in future years. This next slide depicts about the obesity epidemic, as I mentioned earlier, not just being a disease of the United States. Yes, the United States has the largest proportion of patients with obesity in the world, but it's a trend that is affecting both developed countries, like you can see in terms of the United Kingdom, areas of Europe, Australasia, are included in high percentages of obesity, but there's also countries in Southeast Asia, Japan, Korea, they're on this dot and blot figure, also Slovakian, Eastern European countries. So this is a process, the metabolic syndrome and obesity, that's affecting worldwide populations, and it's a trend that's occurring in both the developed world and the developing world. And it's the obesity that results in what we now call non-alcoholic fatty liver disease, a disease that's been relatively least recently defined in the United States and around the world. And non-alcoholic fatty liver disease is the buildup of lipid in the liver. So fat develops within the hepatocyte. The hepatocyte is the primary cell within the liver. It's the functioning cell of the chemical factory of the body, which is the liver. And that hepatocyte, when it gets steatosis within it, steatosis being a fat droplet, develops over time into hepatic steatosis, where thousands and thousands, going into millions and millions of these hepatocytes develop steatosis in them, and then you develop what we call non-alcoholic fatty liver disease, with this steatosis that's then visible on ultrasound. It's visible under a biopsy under the microscope and has the characteristic appearance of fat within the liver cell. And it's caused by a number of things. That includes increased fatty acid influx, insulin resistance, and obesity both prime the liver to be able to do this. So there's more fatty acids that are the substrate for the hepatic steatosis and triglycerides that form in the liver. There's a reduction in the oxidation of those fatty acids, i.e. they're not being broken down, so there's an increased number of fatty acids coming into the liver. There's less of those being broken down, and also there's an increase in synthesis of those fatty acids within the liver. And hyperinsulinemia, insulin resistance associated with obesity, is the primary link of all of these things. And the combination of these things allows triglycerides to form in the liver, and that increased triglyceride formation causes the fat droplets to form within the hepatocyte. And with the non-alcoholic fatty liver disease, Francois alluded to this a little earlier, this is an epidemic in not just the United States but around the world. There's 180 to 100 million people in the US have non-alcoholic fatty liver disease, and worldwide 1 billion people have it. And non-alcoholic fatty liver disease is one of the diseases associated with the metabolic syndrome. The metabolic syndrome occurs in individuals with obesity, and those individuals with obesity have non-alcoholic fatty liver disease, they have diabetes, they have hypertension, they have hyperlipidemia, and a lot of those patients have sleep apnea. We know that non-alcoholic fatty liver disease and obesity and the metabolic syndrome are associated with cardiovascular disease. So these patients develop acute coronary syndromes, they develop stroke, they develop peripheral vascular disease, and they have a high morbidity and mortality. And metabolic syndrome and obesity is one of the highest causes of morbidity and mortality throughout the developed and developing world. This is a slide that talks a little bit about the pathophysiology about non-alcoholic fatty liver disease. And suffices to say that what I would like people to take away from this slide is that 20-30 years ago, people thought that visceral fat was an inert organ, that it sat there in our abdomen and it didn't do anything. And you can see at the top of this diagram that you've got the visceral adipose tissue that's a deposit. It's basically an organ. It's a living thing. It's a cellular system that is secreting cytokines. And that is the nidus, and that is the origin of the metabolic syndrome. Because the TNF-alpha and interleukin-6 and all the other hormones that are being secreted from this organ in the central adiposity is increasing what I talked about earlier. There's less oxidation of fats, there's increased synthesis of fats, there's less breakdown of fats, and that is what's causing the hepatic non-alcoholic fatty liver disease. And in particular, if you look at the right of this slide, there's increasing levels of leptin and reducing levels of adiponectin. Adiponectin helps break down fat. Leptin, with leptin resistance, the resistance of leptin prevents you to break down fats as well, and all of this leads to cellular steatosis, it leads to inflammation, it leads to fibrosis, which then can lead to cirrhosis and liver cancer. So this is a little bit of what I'm talking about that natural progression in the spectrum of non-alcoholic fatty liver disease. The first part of that spectrum is the fat accumulating in the liver, the mechanism of which I've just shown you in the previous few slides. That fat accumulation in the liver, hepatic steatosis, is on the left side of the spectrum of non-alcoholic fatty liver disease. As time goes on, those patients develop inflammation in the liver and scarring in the liver, a condition known as NASH, and 30% of those patients can progress to cirrhosis, which can then lead to liver cancer. So you can see that within the spectrum of this disease, you've got patients with fatty liver, and then you get a patient within that cohort of patients with non-alcoholic fatty liver disease with simple steatosis or fatty liver disease who get the aggressive form of the disease, which is called NASH. That NASH causes inflammation, it causes scarring that can lead to cirrhosis. And this is a little bit what I've talked about, but from a histological perspective, what it looks like under a microscope. You've got simple steatosis in non-alcoholic fatty liver disease on the left side of the slide. You can see down where the mouse is pointing at the moment. You've got these areas of steatosis, which are the white droplets, usually in individuals who don't have non-alcoholic fatty liver disease. These are all packed pink liver cells. There's none of these white droplets within liver cells there. The white lipid droplets are quite visible there. They're occurring throughout the liver. So this would be someone with steatosis, macrovesicular steatosis, we call this. And then a group of these patients who then develop NASH, then you can see that these pink areas within the hepatocyte, those pink areas that I'm pointing to, those is an indicator of hepatic stress. So those basically pink areas and also these ballooning areas, these are called ballooning hepatocytes. Those pink areas are called Mallory's hyaline. They were first described in alcoholic liver disease about half a mile down the road at Boston Medical Center. But now we know that these Mallory's hyaline are also part of the toxic metabolic liver injury that we see in non-alcoholic fatty liver disease in NASH patients. So you get this inflammation, you get the steatosis, the macrovesicular steatosis that I've talked about. You get ballooning hepatocytes. So in these NASH patients, their livers are under stress, and that stress causes inflammation, and that necroinflammation is with inflammatory cells that target themselves into the liver, and then over time you can see on the right side these patients develop cirrhosis, and you can see these blue areas that I'm highlighting here. These are areas of fibrosis. This is where the outline of the blue is. You can see it's called chicken wire fibrosis in NASH, which is a very interesting area because it's perisinusoidal. As you can see, it's like a chicken wire going throughout the liver lobule, and that's what the characteristic lesion is in NASH. It's a chicken wire fibrosis that then causes cirrhosis of the liver, and it's cirrhosis of the liver, the endpoint of which we see is liver failure and liver cancer. So there's significant morbidity, there's significant mortality, and if you can imagine that there's 100 million people with non-alcoholic fatty liver disease, 1 billion people worldwide with this condition, and of that a significant proportion are at high risk of developing NASH, that there's an epidemic of cirrhosis, liver failure and liver cancer awaiting us in the next few decades. So you look at the standardized scoring system for NAFLD, hepatic steatosis and macrovesicular steatosis is at the center of that. Identifying how much fat is in the liver is part of the algorithm to working out whether someone has simple steatosis or NASH, in addition to getting up to 3 points for macrovesicular steatosis. Within the scoring system, you're also looking for those areas that I told you about, which is the hepatocyte being under stress, indicating that the patient is at risk of progression. So you're looking for the ballooning degeneration, scored 0 to 2, and the amount of inflammation with inflammatory cells, including eosinophils, macrophages, etc., into the hepatic lobule, that's scored 0 to 3. And you can get a score up to 8 in the NAS scoring system, where steatosis is a 1 to 3 in the NAFLD spectrum, and NASH is a score of 4 to 8. If we now move a little bit and pivot towards how we take that liver biopsy and staging non-alcoholic fatty liver disease, our gold standard and our reference standard for staging non-alcoholic fatty liver disease, or any liver disease, in the last 50 years has been the liver biopsy. This has been it's been the reference standard for etiology to identify what the cause of someone's liver disease was. It's been the reference standard for grading the inflammation, the amount of fibrosis to confirm whether there's cirrhosis. But the liver biopsy has significant risk associated with it. In terms of risk associated with it, it's invasive. It causes anxiety to patients. They have to come into hospital. There's morbidity and mortality associated with it. So 1 in 2,000 people who have a liver biopsy will have a significant intra-abdominal event, either a perforation or a bleed, that will either lead to surgery or death. So that is the major risk associated with a liver biopsy. And that's what really defers a lot of patients in my clinic from wanting to get the test done. And it also then creates momentum to look for other non-invasive tests as an alternative to liver biopsy. Other issues around liver biopsy include its sampling error, in terms of you're only sampling 1/50,000th of the liver volume by taking about a 2 centimeter by 3 millimeter liver biopsy slide. The length of the biopsy is basically, it determines accuracy. The number of biopsy performed determines accuracy. The type of needle that's used for liver biopsy determines the accuracy of it. The person reading the liver biopsy determines the accuracy of the liver biopsy. So there's a number of different things involved that make liver biopsy, even though it is the reference standard, and it's an excellent reference standard, increase the risk associated with it that creates the impotence for us to basically look for non-invasive tests associated with those risks with liver biopsy. So moving on to non-invasive markers in non-alcoholic fatty liver disease. On this slide, I've talked a little bit about biomarkers. And biomarkers are blood markers that assess whether you can make an assessment of the severity of the diagnosis and of the severity of NAFLD. And in this, one of the biomarkers that we looked at was cytokeratin 18. And when I talked a little bit earlier about stress to the hepatocyte and inflammation around the hepatocyte being an indicator of progression in non-alcoholic fatty liver disease from the steatosis phase to NASH, which where the patients are at risk of liver failure, liver cancer, and cirrhosis, then cytokeratin 18, the idea behind that was that it's a marker of apoptosis, it's a marker of necroinflammation. The issue around cytokeratin 18, though, was because it's looking at only apoptosis, it's a surrogate marker for non-alcoholic fatty liver disease. It's not actually grading the amount of steatosis there, which is a very important component, and therefore it didn't give us a high enough diagnostic accuracy in terms of an AUC, which is the area under the receiver-operator curve. And when we do diagnostic non-invasive tests in any condition, whether it be hepatitis C, hepatitis B, or NAFLD, we look for an area under the receiver-operator curve of 0.9 or above. And cytokeratin 18 didn't use that, didn't make that threshold, and nor did any of the markers for fibrosis. The APRI score that looks at AST over platelet ratio, the FIB4, which includes age, AST, ALT, and platelets, or the AAR ratio, that's the AST to ALT ratio. And interestingly, that the APRI, the FIB4, and the AAR are all just looking at fibrosis. They're not looking at the underlying pathological lesion in non-alcoholic fatty liver disease. So these biomarkers are looking at surrogate markers. They're looking at fibrosis, they're looking at apoptosis, hence the area under the receiver-operator curve is not good enough to match up to the diagnostic accuracy that you'd want for a non-invasive test in non-alcoholic fatty liver disease. So then we move on to hepatic elastography. Transient elastography is a rapid non-invasive measure. We were talking about this for a few minutes prior to the presentation, that this is a rapid non-invasive measure of hepatic stiffness. The hepatic stiffness of the liver correlates with the amount of liver fibrosis. So the probe is pressed against the right intercostal space, underlying which is the liver. Then a transducer pushes an elastic shear wave through the liver that goes through an explored volume of 4 centimeters by 1 centimeter through the liver, and that shear wave then reflects back into an ultrasound probe, and that ultrasound probe gives you a kilopascal reading of fibrosis. So that's, again, a measure of liver fibrosis in patients with non-alcoholic fatty liver disease, not looking at the underlying lesion in NASH. So moving on to a different marker of liver fibrosis, with the small explored sample volume of hepatic elastography. Again, as I mentioned earlier, we're looking at a 4 by 1.5, 2 centimeter explored volume with the FibroScan maximum, usually around 4 centimeters by 1 centimeter explored volume. You're looking at about 1/10,000th of the liver now, compared to MRI elastography, where you can see you're getting a much more explored volume of the liver. So the assessment of fibrosis is much more accurate with MRI technology and MRI elastography. As you can see in this figure, if you were looking with a FibroScan in this area, you'd be basically thinking that your individual patient has a low fibrosis score, whereas if you were looking in this area with the MRI, you can see that this further characterizes that cirrhosis, fibrosis is a very heterogeneous condition, and even in individual patients, you can develop cirrhosis in one area of the liver and then it expands out over a period of time. And in this patient, if we'd done elastography, we would have missed cirrhosis, and we would have missed it if we'd done it lower in the liver compared to higher in the liver, but on MRI you're picking up that cirrhosis. Now, the limitations of the current non-invasive tests we have to look at in a staged way is that with blood tests they lack the sensitivity and specificity to reach the diagnostic threshold and AUC of 0.9. I talked a little bit about that. The elastography readings, they're limited by necroinflammation, they're limited by obesity, they're limited by cholestasis, they're limited by ascites. We can't do hepatic elastography in that group of patients. Again, you're looking at a small explored volume with these group of patients, especially when I showed you the diagram of the explored volume, compare it to liver biopsy, it's a little bit better than that, but it's still 1/10,000th of the liver. The CAP score on the hepatic elastography is a relative measurement and it's prone to inaccuracy. And then the MRI elastography is looking at fibrosis, so you're not looking at an area of the liver in terms of the fat, which we grade in non-alcoholic fatty liver disease, but you're looking at fibrosis with MRI elastography, and also the MRI elastography, because it's MRI technology, it's very resource dependent, access is difficult, affordability is difficult, getting insurance approval is difficult for this type of technology. So I think it's very important that we look at non-invasive tests both within the context of diagnosis, but we also look at them in terms of therapeutics and the advances that are rapidly occurring in non-alcoholic fatty liver disease. So you look at these 50 companies that are currently developing compounds and drug development in NASH, and you look at them and 34 of them are in phase 2 or 3. We expect 4 to be commercially available in the next 2 years. But the interesting thing about this is that they are so dependent on the assessment of NASH in their clinical trials. So unless you are able to determine and differentiate severe steatosis and NASH from patients who have simple steatosis, it's very, very difficult to identify whether your molecule is actually effective, which is why a lot of these companies have had difficulties with enrollments, because it's involved serial liver biopsies being performed over short periods of time, and patients not really wanting to be involved in biopsy-based studies. And so the development of a point-of-care non-invasive test for NAFLD and NASH is required to accurately diagnose NAFLD and steatosis, not just in terms of for diagnosis as a non-invasive means of diagnosis, but also to help not just in clinical practice but in clinical trials for us to determine whether these compounds longitudinally will be effective. And once we can get to a phase where we can develop a point-of-care diagnostic test for both clinical practice and NASH, we'll get more and more molecules coming out at a quicker stage in drug development, because we'll have markers and we'll be able to address and we'll be able to have patients enrolling in more clinical trials. So I think the non-invasive test should provide diagnostic value, and it should improve accessibility with affordability as well at the same time. So I'm going to leave it at that and pass it back, and I thank you all for your attention.